You may or may never encounter this. If you work in the ER, you might. Primary care, you might, depending upon your patient population. The only time I really encountered malaria or was scared of it is when I went to Vietnam. So I had to do prophylaxis the both times I went because I didn't want malaria. And every time I saw a mosquito, I thought I was going to get malaria. So I had that. The skin's so soft, you can spray that on you too. And that's why if you see, and that may be why, or they're just acclimated to. When I went to Vietnam, all the people there, we went during our winter, which would have been, like December, but it was their winter, but it was 80-something degrees, and these people are in, the sun's beating down on you. They've got long sleeve shirts on, and hats and stuff. I'm like, I take a shower and you walk out and I'm sweating again, that's how hot it was. But maybe they do it for sun protection as well, because they are out in the sun a lot and they're driving around on mopeds. But it also could be for malaria protection as well. Because after, I think it's dusk, after dusk is when the mosquitoes are bad. But that's the only time I really encountered malaria. So these are just basically the generalized lecture objectives. What I really want you guys to get out of the malaria lecture is the types of malaria. There's, I think, 5 or 6 different types of malaria. The presentation of a patient who might have malaria. And the key is really taking a good history. Because if you don't elicit that have traveled or recent traveling, then it could look just like any other viral illness. So, and then I think Dr. Latassi is going to do a lecture on the medications of malaria. I do have them in here for completion's sake, but if there are any pharmacology lecture questions, she may, it will be coming from her lecture. So what is malaria? So malaria is a potentially life-threatening disease. It is caused by infection from a mosquito. And it's a protozoa, so they're the Anopheles mosquito is the vector. It's usually a female. And again, it's usually in someone who's in an endemic area, so Africa, Asia, following a mosquito bite. Not saying that all of those mosquitoes in Asia or Africa carry them, but the risk is higher in those that are endemic to that region. So in the U.S., approximately 1,500 cases of malaria have been reported each year, and a lot of them are just mostly recent travelers. So somebody coming from another country, having gone home to visit family, they'll come back and just start developing an illness. So that's why, even though I'm second generation, coming back from Vietnam, I was scared that I might have it. So between 1957 and 2015, in the U.S., there were 63 outbreaks of locally transmitted mosquito-borne malaria. And so basically, like I said, it's travelers coming in from another area. There are mosquitoes that are in the United States that carry that, the Anopheles mosquitoes. They're vectors, so there can always be a risk of getting a resurgence of malaria in the United States, but it's less common. So this is just a little bit about malaria worldwide. 3.2 billion people live in areas that are at risk for malaria. They say that in 2015 they caused 214 million clinical episodes with 438,000 deaths. Again, malaria is dependent on the climate factors, temperature, humidity, rainfall. It's usually in tropical or subtropical regions. And like we talked about, the most highest regions is in South Africa, and Papua New Guinea, which I thought was kind of interesting. But I know it's very high in Asian countries as well. So these are the 5 different species known to cause malaria in humans. P. falciparum is the one that you'll see most often because it's mostly endemic in Africa. But it is also the most fulminant kind. So these people can die from this type of infection. And P. vivax is also, I think this is the one that can be live in the liver. I think it's this one, I'm pretty sure this is one that can lay dormant for long periods of time, and then these people may develop jaundice, hepatosplenomegaly, those kinds of things with this type of protozoan. And then P.O. Valley infection often resolves without treatment. And then the P. malaria is one that can last much longer and is associated with nephrotic syndrome. And then the P. knowlesi, these are usually found in monkeys. But I think the upcoming thing is that it can occur in humans as well. But majority of them is, it infects monkeys in Southeast Asia. And that's why it's called more of a zoonotic malaria. But so on those, I just kind of want you to be familiar with the names of the different species, Plasmodium, and then which ones can affect, you know, if there was a scenario and there's someone with a splenic rupture or spleen disorder, you would think maybe P. vivax. And then obviously the ones with the monkey, if there's a scenario with a monkey in it, it's the knowlesi. There are different types of transmissions other than the normal, like we talked about. You can have what's called airport malaria. So this is kind of scary. It's like malaria that are caused by infected mosquitoes that travel in the luggage that can show up in an airport and can bite a person in the airport. So that's why they call it airport malaria. And then you can have congenital malaria. So again, you wouldn't know this unless you have a history of the mother recently traveling and pregnant as well. But it's rare, but you should also be aware of that if you're treating a pregnant woman, just to get the history. But hopefully this woman hasn't traveled. I think traveling, do y'all remember when you can't travel by plane and a pregnant woman? What week? Ever learned that in OB-GYN? I want to say it's like 32 or something like that, or 36. There's something like that. There's where you should not travel at all, at least flight travel. And then transmitted malaria. It can happen, it's rare. They say there's about one case every 2 years because there's really no testing for blood that is donated for malaria. So screening, I guess I said, screening for donated blood. So pathophysiology, yes.
Why can they not travel at that many months?
I think it's a risk of a DVT. I think it increases your risk of DVT.
Oh.
And then I think also a risk of premature labor. After a certain amount of weeks, you're at a higher risk of premature labor. So they don't want you traveling and having a baby up in the skies. I don't know. But that's always told. I just don't remember if it's 32 or 36.
Okay.
That's all I know.
I'll look it up.
Then you look that up for me and you get back to me and let me know. I know I knew that back in PA school because that was one of those things that we had to know. So the malaria parasite cycle involves two hosts. The vector, which is the Anopheles species mosquito, transmits something called plasmodia contained in the saliva into its host while it's feeding on the host. So when I read this, it was a little, so basically you can have an infected, there's two ways of it. You can have an infected mosquito that feeds on someone, gives them the disease. Or you can have someone who has the disease and a mosquito that is a normal mosquito feeds on this person, then they get it into their saliva, and then they turn around and, it's a progression, and then they feed it onto another normal person and they give that to them. So there's different ways. So in humans, the parasites grow and multiply first in the liver and then in the red blood cells and the red cells of the blood. And these continue to grow. Originally they are, I think they're called they're asexual, and then eventually they can form gametophytes, which will be male or female, and they're called heterozygotes, and then oozygotes for females. That's a little bit more than you will need to know for the exam. But so basically they replicate in the red blood cells, and release toxic metabolites into the bloodstream. And that's when your patient gets sick and they get like flu-like symptoms of headache, fever, sweats, those kinds of things. And then, oh, here you go. So some parasites differentiate into gametocytes and are ingested by a Anopheles mosquito during blood meal, and the parasites multiply, grow into sporozoites, and make their way into an infected mosquito salivary glands and transmit it to another human, perpetuating the malaria cycle. There's a nice little graph here by the CDC that kind of shows you how. So here it is, you get a mosquito, they bite a person, they form sporozoites into the liver, and they grow red blood cells at first, infecting other blood cells. Oh, sorry, here it goes, 1, 2, then 3. And eventually a person recovers, so they can still have that disease remaining in them, and then another mosquito feeds on that person, and then they get the disease and then bite a normal person. So this little graph was pretty helpful as far as the pathophysiology of malaria for me. Incubation period, I actually have a better graph that I found in a book that I can make a copy and send it to you all. It just gives a more succinct incubation period, and it also gives a region by region of where certain endemic areas are. So the P. falciparum typically develops 1 month after exposure. So when you end up giving your patients prophylactic, you'll see that they take it before they leave, while they're there, and then they also continue it for a month when they get back. That's what I had to do with doxycycline. And then P. vivax and P. ovale, they emerge weeks to months after the initial infection. So in addition, P. vax and P. ovale have a hypnozoic form during which the parasite can linger in the liver. So this is the kind that can stay dormant for a long time, and they can have a recurrence after the initial infection. They can have relapses. And then with relapsing, they can get liver disease, and these are the patients that can develop jaundice. The shorter periods of incubation are usually with the P. falciparum and longer with P. malariae. I don't think we talked about that. So signs and symptoms. In these patients, like I said, it can mimic a common viral syndrome. Usually they will develop headache, they get fever, chills, and sweats, and then cough, fatigue, malaise, arthralgia, myalgia. So that could be someone who has a flu, someone who has just a common cold, any other viral illness that can kind of mimic. And there's just some other less common. They can have anorexia, lethargy, nausea, vomiting, like I said, diarrhea and jaundice if they're having relapses and it's affecting their liver. So some signs and symptoms. Physical findings, they may have splenic or liver enlargement. They can have fever, like I said, mild jaundice. For the fulminant one, the P. falciparum, I can't even say it. They can get cerebral malaria. Some can develop anemia from the lysis of the red blood cells. Some can have respiratory abnormalities, and then typically some of them can have renal failure. Again, these are some differential diagnoses that they can present as that you may think it may look like. And so how do you diagnose it? Basically, you have to do an in-depth history. Order labs, you can do both blood culture, CBC, CMP, and you can also do a chest x-ray if they have respiratory symptoms to rule out like a pneumonia or anything else like that. And if they have any neurosymptoms, you can do a CT of the head. Good. The gold standard is peripheral blood smears, multiple smears, and with these tests you can see different staining techniques and you can see things that are common to malaria types, the parasite under the microscope. So there's other things you can use. They have PCR tests, rapid tests, but some of those aren't available in most places. So a CBC with a purple blood smear is your best option. I don't think CBC does very well, but these are what they look like under a microscope. So the gametocytes are what you see a lot with malaria. So treatment-wise, failure to consider malaria in the differential diagnosis of a fetal illness in a patient who has traveled can result in increased morbidity and mortality in these patients, especially in children and in pregnant or immunocompromised patients. So, you know, if you have someone that could have been traveling, that's the key is having, you know, and I think nowadays, even in our, remember when there was that big Ebola outbreak? That was part of my nurse's duty, was to ask them, have you traveled anywhere in the last 30 days? No matter what they came in for. That was just part of the history taking. So I don't know if they're as lax now, since that outbreak has not been as current, but that's something you always think about your patient who's coming in with a, you know, a viral type illness, is to make sure you ask them if they've traveled anywhere. There are 4 major drug classes currently used to treat malaria. The quinine-related compounds, antifolates, artemisinin derivatives, and antimicrobials. So there's no single drug that can eradicate the parasite's life cycle, but a lot of times you'll use combination drugs. You might use an antimicrobial with a quinine, those kinds of things. So again, treatment regimens are dependent on the geographic location of the infection. The likely Plasmodium species, so you have to figure out where they've traveled, which protozoan is endemic in that area, and that kind of helps you give you an idea for prophylactic as well as for treatment of the infection. And again, you know, I've yet to have to treat anybody for malaria in my clinic practice in the last 10 years. I have given out prophylactics when they've traveled. But what I do is I usually go on the CDC, and if all fails, if you don't know where to start or where to begin, you sit there in the ER and you don't know what to do, and you've got a patient who you think might have malaria, you can always call the CDC. They can help you figure out a game plan as where this patient traveled, the most common one it could be, and the best treatment option for you. So these are the different types. Like I said, you guys can read these on your own, and like I said, Dr. Latassi will have a more thorough lecture of them. The only ones that I was really familiar with is the quinines, that second one right there, as far as treatment, because it was only used for malaria treatment. And like I said, the only other one I was familiar with is doxycycline. So I would use that a lot for my patients who travel. I would give them doxy. But the problem is a lot of your patients, even if you treat them prophylactically, why they get sick when they come back is they don't finish out their treatment. That's the biggest factor in malaria from somebody who's traveling, is they don't finish out their treatment. Malarone is approved in the United States for prophylaxis and a good treatment of mild chloroquine-resistant malaria. Mefloquine, I don't really know a lot about that. Clindamycin can be used as a combination therapy, and it can be used for a second agent in pregnant patients. And what I was really scared about using doxycycline, what's the major side effect of doxycycline? Well, no, like for me, like I was going to, when I was traveling, and I'm going to Vietnam.
Oh, light sensitivity.
Right, light sensitivity. I was afraid I would get sunburned for the 4 weeks I was there. So that's one thing you need to tell your patients too, is anytime you give them doxy, is sun sensitivity. And then Coartem is a combination drug that is indicated for treatment of acute, uncomplicated P. falciparum malaria. So a lot of these, treatment-wise, you may start them on it, but most likely if you think someone has malaria, especially in an ER, you will have consulted an infectious disease doctor to come down and give you a lot of these. Like I said, the only ones I'm familiar with are the quinines and the doxycycline, because that's the only thing that I used in clinic. So this one's kind of a ugly little table, so like I said, I have a better one. My computer wasn't working, so I wasn't able to change this from the last year's slide, this little guideline treatment. Yeah, because it's kind of a really long, ugly slide. So basically, the ABCDs of malaria is awareness. So anybody who's going to be traveling or having come travel back, kind of recognize that they could be a risk for malaria. Bite prevention, like I said, after dusk, you know, your patients, if you're having them travel, or if they're going to travel, you might want to recommend that they don't get out, or if they're out, they need to be wearing long sleeve shirts. You can also get DEET spray or prevention on them, and then also when they sleep, I did sleep in these like little net things, you know, over the bed to help prevent mosquitoes at nighttime, at bedtime. Because in these countries that you're going to, there's not a lot of air conditioning, so most of the time it's going to be windows open at night, doors open, that kind of stuff, and that's where they come in at night and bite you. And then chemoprophylaxis, using preventative medication, and then early recognition and diagnosing and treating is a big part of malaria. Oh, here we go. So, what I just said. Using long clothing to reduce exposed skin during body periods, dusk to dawn. Topical repellents, mats, lotions, vaporizers. Like I said, I've heard Skin So Soft was a big one that was back, you know, you can buy from Avon. Some people said like Bath and Body products because it's really sweet, you can use that as well, but I would think it would be the opposite. Giving them prophylaxis with medication, but again, doesn't provide 100% protection. And there it is. We're using the anti-malarial dosage 2 to 20 days before departure, and usually a week to 4 after their return, depending on what regimen you end up giving them. And this is just a table of the medications. So the reason why, I think, because you know they're once daily, you could give them mefloquine, it's once weekly. And the cost of care, I guess, let's see, this one's the most expensive, the Malarone. But I think they just did this because it's just easy, doxycycline. Dosing is about the same for regular dosing if you had it to treat it for an infection. And that is it.